I wanted to be independent. I wanted to do the things that I was able to do before, and luckily I now can.
They make way for you, they listen to you talk, they can advise you, and they do every earthly thing for you. You are satisfied, you are confident.
I was just happy to be back home because I knew that my blood pressure would go down when I was in my own place.
I was quite surprised exactly what the team had to offer for Dad and other people in his position. You know, obviously the equipment that they brought, and didn't seem to be any limit on it. If he seemed to need it, it was there.
Being at home is far more comfortable than being in hospital. I've never, I can please myself what I do.
They were just brilliant, absolutely brilliant. But it's a system that the common person, ordinary person, knows nothing at all about.
And when you see someone in hospital, you automatically assume that they're ill. When someone visits them in the home, they're looking for them to be happy, to be better each time.
The aims of intermediate care are to prevent unnecessary hospital admission for people from home, to support a discharge to a more appropriate environment once they're well enough to leave hospital, and to try and prevent long-term admission to long-term care.
I like to see it as a huge safety net, in that we have such a range of services, we can meet your needs whatever they are.
There are many routes into intermediate care. People can refer themselves. They can be referred by district nurses, by general practitioners, staff from the hospital. We have our own assessors in the community that would go out to people's home to see people and assess them.
We met Ron after we'd had a referral from his GP asking us to come and assess him to offer him some support after he'd had a fall.
Even though the fall was quite considerable, there was no broken bones. So the GP came and he told us about the occupational therapist. They could come and try and treat him in his home.
The first thing we did was put in equipment, so we're maximising his independence. Then the next step was to put in care from our multi-skilled assistants.
We go in after the therapist to really help Ron in his everyday needs. We assist him in getting dressed and washed, and also preparing his meals and his drinks.
As a GP, the way I would use intermediate care is if I'm concerned about a patient, I'd refer them to the team. If they think they can manage them in the community with a little extra support, they do that. But if they see they can't manage that, then they take them onto the bedded unit.
It's not a hospital. I think the team here are very keen to deal with the residents as if they are in their own home.
The difference between hospital and being in Anne-Marie House is that you have your own independence.
They start you off here when they think you should be all right. They start you off here for you to make your own breakfast in the morning.
You are made to do things by yourself or on your own, so that you go out into the community and look after yourself.
Bedded unit is a step down from hospital. Clearing the beds and improving the care of patient by helping them to avoid becoming more confused, staying in hospital, becoming exposed to hospital acquired infections.
I told them my first aim was to be able to get upstairs, because I wasn't going to have a bed downstairs. And I did that, I believe, in about 2 weeks, and I was up and downstairs on my own.
Each person's goals are going to be different. So we have to work very closely with them. It's not about the goals that we think they need to achieve, it's about what they want to achieve. They gave me confidence in walking, looking after myself, making tea. We did some baking. And I say lots and lots of physiotherapy, which was very, very good. They've got round-the-clock nursing care, physiotherapy input, occupational therapy assessment, a GP to visit them, who visits the unit every day, or a consultant if need be.
Like if I've had 2 falls, and I couldn't get into bed. So they came in and they used to lift my legs up and put me into bed.
It was crisis point and we needed to get help quickly. So the community matron came in, assessed and said intermediate care would be here within 3 hours, but they were here within 90 minutes.
We can sort of cater for patients with very complex needs, people that are extremely ill but really choose and want to be nursed at home or remain at home.
We try to keep them at home if we possibly can, because people always respond better if they're either at home or close to home.
The best thing about intermediate care is it's a team of professionals that all work together to achieve a particular outcome.
I work parallel with the other members of the multidisciplinary team, looking at the mental health aspect of the clients that are referred to the intermediate care service.
Having a social worker working within the team I think works better for the patient. It's more joined up working. I can get information from the OTs, the physios, the nurses, and they can get information from me.
I prefer to work with people in their home because that's the real person. You can see people on a hospital ward and it's just not them, you know, you've got the real person.
They treated Dad as a gentleman, they looked after him and they cared for his personal being as well as his medical being.
It was a bespoke service and it seems to suit the need. It's not one thing fits all, it's to the need.
Had he have gone in hospital, he would have been in there 3 or 4 weeks, get muscle wastage of his legs, he'd be bedridden and he wouldn't be here today if it wasn't for intermediate care.
We empower our patients and we give you your power back to be listened to and to be heard and have your opinions taken notice of.